Well, welcome. Tonight, three people who have a lot of influence over our families, our life, who've taken the little red Milford Hospital and grown it into a world-class medical center. Why don't we start with introductions?
Good evening. I'm Peter Smolowitz, Chief Medical Officer.
Hi, Al. I'm Pat McSweeney. I'm the president of the physician group.
Ed Kelly, President and CEO of the Milford Regional System.
And we've had you on before. Ed, why don't we start with, overall, we don't hear any good news about community hospitals or med centers.
Yeah. So, I think, first of all, just to speak to the healthcare industry, Al, it's a struggle. All of us are dealing with, for us, pre-COVID reimbursement rates and expenses of managing any business, from restaurants to hotels to healthcare, has gone up exponentially. So we're all struggling to some regards. Through the COVID period, we have gotten some government relief, which is very appreciative, but overall the numbers still adding up. And we are hopeful still in terms of some government relief, particularly and hopefully soon from the state, as they balance their budget and try to come up with a final distribution of funds, some of which has come in from the federal government.
Now, we'll ask Pat about primary care physicians and all, but as a general question, I had a young man living with us who was working at Amazon making $20 an hour taping boxes. How do you compete with that?
It's very challenging. I think a lot of it for our staff is the mission of taking care of patients and working together. So I've been at Milford Regional for 29 years. And really, we're still, even though we've grown a lot, we're still a relatively small healthcare system. And there's still really the feel of family at the hospital and really mission. So I think it's really a dedicated team throughout our system, from our physicians and nurses and ancillary support staff, also over to the physician group in urgent care centers in terms of what they do. So we all work as a team. And I think that camaraderie really makes a difference.
I mean, when I think about primary care physicians, that always seem to be the hardest to recruit for. Is it still that way?
Al, I think it's, it comes in cycles. I think, 4 or 5 years ago, we maybe were lucky if we had 1 or 2 physicians, primary care physicians, accepting new patients. We're in a good part of the cycle right now. We maybe have 8 to 10 who are doing so. But it's not just physicians, it's nurse practitioners as well, who are increasingly taking care of more and more of the primary care patients as the supply of primary care physicians is not increasing and is in fact decreasing. But I think we're in a pretty good place right now in our system for primary care.
So are we able to recruit support staff?
So Al, I was just going to jump in and say, I think of this in 3 phases when we've been here before. Early on when I was here, there was the issue of recruiting physicians. That was the primary thing we were talking to you about, is that patients in our community really wanted to participate in Milford Regional, but they were having trouble with access. Physician panels were closed, and I think Dr. McSweeney is really modest in terms of the impact he's had, because recruitment has really ramped up, which, again, is good for our community. Our model of getting care, mostly care locally, but knowing that we have these relationships with Boston and Worcester hospitals. So I think we've gone from really struggling to get into a physician practice to great recruitment in terms of of having a lot of physicians that really want to be here, great physicians. Our third phase right now, which you've kind of alluded to, is we might have been here a few years ago talking about trying to bring physicians to Milford. Now it's hiring staff throughout our system, really at every level. What you hear on the news often is, there's no lifeguards, or there's no one to staff restaurants, or restaurants are closing certain hours. That carries directly over to us in the hospital. So our ability to kind of staff throughout our hospital, it's not now about physicians, it's about support staff to support physicians. And so we're working really hard at that, but that's I think that really emphasizes that it's a whole team effort here at Milford. It's just not one person in a practice. It's the whole team supporting patient care.
Have you had to raise your salaries to compete?
Absolutely, and that, again, is a challenge because what I think folks don't always realize is healthcare inflation hasn't gone up because we're living off of pre-COVID reimbursement, but the cost of providing that care has gone up really dramatically throughout our state. It's probably most notable in terms of what's in the media, in terms of a real shortage of nurses statewide, and that's been compounded a little bit by the change from many of our nurses to go to agencies, and so we're like every other hospital using agencies to staff our hospital.
But now, we had X number of nurses pre-pandemic. Where did they go?
Where did the lifeguards go? It's a change in the culture of our society. Retirement, being home for a long period of time in the early stages of COVID probably have an impact. I think we'll still be studying this for years in terms of where did the workforce go.
Well, I can see if you go through an agency, now you're adding 20% to the cost.
Yeah, I think you gotta add a digit maybe to that a little bit, but
Oh my God.
it's expensive. It's not a digit to that, but it's higher than that.
But if we had 100 nurses servicing Massachusetts before, as I said, where'd they go? They cost you more.
Yeah.
But they're still here, I would think. Or is that naive?
Well, I think there's a lot of dynamics. Kids in school, parents needing to be home, lots of remote activity. I think there's lots of things that have changed the workforce.
Now, one of the things I always admired is when I have the physicians on. I love when they say, well, I'm relatively new to Milford. I've only been here 30 years. I mean, that to me says more about the culture that you've set up than anything. What's so special about Milford?
I wish I knew, Al, but I came from another system 22 years ago, and I noticed it on day one, and I've told the same story over and over again about the difference in working my last week at the place I used to work with and what the atmosphere was like there, and then the first day I rounded at Milford, back when primary care docs rounded for themselves before there was a specialty called hospitalist medicine, and just the community family type atmosphere. I remember it as if it was yesterday, and it was 22 years ago. And I think it is something very unique, and it's something that I've tried to focus on as well. Is when I hire someone, I kind of jokingly say, you just signed a contract for life, right? Because we want you to retire here, and that's kind of the approach we take. And I really think it's about the people and the community. It really is a true sense of community, whether you're in the hospital, one of the physician practices, or anywhere else within the healthcare system. It really has that family community feel to it. I think that's what makes it special. I really do.
Now, Peter, somebody in your position, why Milford? I mean, when you think about what you bring, the fine-tuned, high level of experience, you could go anywhere. And Boston's not that far. What brings you here and keeps you here?
Well, first, I appreciate the comments. I think you're far sort of overstating hopefully my capabilities. But all joking aside, I will just sort of add on to what Pat was saying, that the moment that I walked in the doors at Milford about 2 years ago, and I had spent the rest of my career sort of in the Boston hospitals, there's just something palpably special about Milford, and you almost can't define it, but it's a family. Some of it may come down to the fact that I think we kind of know we're on our own as an independent community hospital and rely on each other for that survival. But we lean on each other. It's truly a family. There's respect all across the board, and I could never think about going anywhere else. It's like Pat said, once you step in the doors of Milford, you're for life. And I think that's why also we attract physicians from all around the area. We have people working at Milford from UMass, from Brigham and Women's, people through Milford Regional Physician Group, people from Boston Children's Hospital. it's a remarkably diverse group of clinicians who all come together for a single purpose and really work together as a team to provide excellent care. So I don't know that I can define it, but maybe what I said, defines it enough, which is it really is a unique family situation in some ways.
I remember once I was out in the Midwest, we were doing it was an aortic valve regenerative medicine convention, and I was talking at it, and the people there at that little medical center called Mayo, I mentioned that I was really impressed with the dedication and the attitude of the people. I said, that's almost as good as the Milford Medical Center. They did take a little bit of license to say they didn't consider themselves lower than anybody. But then again, you've got man's greatest hospital, MGH. You've got Brigham. And I read that a community medical center is very, very fortunate to have an alliance with a teaching hospital.
Correct.
Milford doesn't have that.
No, we have it with 4.
How did you pull off 4?
I think there's always a little skill and luck that goes with that. Geography also is a factor in terms of where we're located. But I think it ties into what Pat and Peter said in terms of Milford being a special place. So it really is about, for me, coming to Milford was making a difference. I was talking to my wife, she said, "You're not going there." And I said, "Yes, I am." I said, "There's something special. It's using my ability." And I think, Pat's transition from practice to running the group, it's a huge responsibility because it's about bringing resources to Milford in terms of taking care of patients. And Peter, little did he know, if we told him ahead of time, he was going to come in and champion the COVID initiative with no playbook. It's incredible, but I think that is really throughout the whole system. And I think to answer your question in terms of academic medical centers, it really kind of comes down to those relationships in the fields. And it's not like there was a grand plan to bring it forth. It started really with the basics of UMass looking to put a residency program in a community in terms of teaching, because at the academic medical centers, there's a lot of fellows and senior people there. And so coming to a community is sort of the real world in some ways for physicians. And again, not every setting is right for a physician. So it really started that way. And boy, were we lucky that the residents liked it here, and they liked a community hospital with residents. And so what we realized is we didn't have that vehicle to employ physicians. So now we've got, Pat's group, and it is about bringing physicians to the community. And so a big part of that is through employment, but also a big part of it is through the academic medical centers. So to have your doctor that can come from the Brigham or UMass and do a lot of stuff at Milford, but then if it's a higher level of care, they themselves sometimes can bring you to the academic medical center. So that's really terrific. We still have a number of important and very valued private practice, but they're less and less, and certainly a lot less than when I came here. So and then just to round out, to have UMass. We have Boston Children's as well, which is really terrific. Dana-Farber and Brigham, it's really special. And it really evolved over time, and it always evolved in a way of what's good for patients. And often it's if we can take care of them in the community, that's the best. It's actually lower cost, but really it's convenient. And certainly for elders, it's super convenient.
My mother, when she went through her cancer treatment, it made all the difference in the world of driving, 2 miles to the hospital that she knew. Of course, she'd never recognize it because it's not the little red building we grew up in. But it was the tension level was so low compared to getting in a car, driving to Boston through the traffic, getting into this medical center that you didn't know what it was about. Until she passed away, every 6 months she went to see Dr. Mona. It was just a given for her, and she felt so comfortable. It made compliance that much easier because she wasn't scared to go. Now, how does it feel to be chief thief of medical professionals? I understand you keep a lot of them. That they come in here, they interned on a trial basis and you don't let them leave.
I don't know how true that is, Al, but, I think more so, we've been fortunate that we've been able to add some local physicians who, have had practices in the area but not part of Milford system that have been joining in the last couple of years and bringing patients from out in the community but outside our system into it, and I think that's been a real benefit. I mean, certainly from a business point of view, to bring in a doc who's already got a panel of patients is a faster business model to success than starting from scratch and, starting with 0 patients, although a lot of times that's kind of what we're looking for because of the demand. But we've had a good mix of both. And again, I think it goes back to the question you answered before, why are we being successful? I think it's everything we talked about before, community, family, dedication to each other, those things.
But there must be, 6 or 8 primary cares that aren't part of your system?
Really just try River,
Yeah,
which
yeah.
again is very much part of our family.
I was going to say, I don't think I can think of half a dozen physicians in the area that don't belong to your group.
Yeah, I mean, I think part of it is, the model is it's tougher and tougher to run your practice, negotiate with the insurers, be a business person and be a physician. So I think those are becoming less and less common. And, we hopefully try to take away all those additional responsibilities and let you just do kind of what you were trained to do, is really take care of patients. So that's what we try to do.
But is that the driving force? I mean, I don't envy an MD, especially a specialist, because by the time you guys get out and you're ready to hang your shingle, you're almost retiring age, but you wonder, why do they join a group like Milford Physicians versus going out on their own?
Yeah, I think one thing, especially when you talk about specialists, Al, is, and I think it's a big selling point for us, you have a built-in referral base. You don't have to go out and hustle for patients and referrals. You've got, 50-something primary care providers. You've got 80,000 patients we have 80,000 patients that our MRPG primary care providers manage. That's a pretty good referral base for a cardiologist, a pulmonologist, a neurologist, an infectious disease specialist, an orthopedic surgeon, an ENT surgeon, et cetera. So I think that's a big part of it.
Now, how do they keep you interested? You could be at any medical center in the area. Do we have the equipment, the technology to stay cutting edge?
The simple answer to that question, I think, is I was commenting recently, I forget in what form I was saying, if you sort of put a blinder on the name of the hospital at Milford and look at just the doctors that work there, you couldn't tell Milford apart from any hospital in Boston. Aside from obviously, as Ed's talking about, like the complexity of some of the things we just don't do at Milford and really shouldn't be part of a core service line for a community hospital. I think we do everything that I shouldn't say everything, but most of the things that a community hospital should do, I think we really do them very well. And part of that is hopefully the commitment that we have to, supporting the people that work at Milford. And a lot of that is just what the physicians bring themselves, the quality of care they provide. I think you cannot distinguish it from some of the top hospitals in Boston. Just look at, getting, the quality ratings that we have from Medicare and from Leapfrog. I mean, it's incredible what the doctors at our institution, I shouldn't say just doctors because it really is a team effort, but the healthcare teams at our organization have been able to accomplish.
Well, I've been amazed because, was it the accelerator that we're getting a second one of?
Oh, the linear accelerator, yeah, that's at Brigham and Women's across the street, so they have a second linear accelerator now for cancer treatment.
But they're so rare that, they limit how many are in the whole state.
You need a regulatory approval, right?
And we get 2?
We got 2, yeah. When we built, when the first one was built, there was a question, would we ever need a second one? And so certainly it's been super busy, yeah. So again, it's sad because you don't want to say, okay, well, we have all this cancer, but I think what it really means is that patients can get local care, and together with Brigham and Women's and Dana-Farber is, really, terrific.
It's not even that level of complexity, but think about, we have 3 robots in our operating room now, up from 1 a couple of months ago. So it's incredible the level
3
of
Da Vinci's?
sophisticated robotic surgery we can do.
Yeah, and that's because the newer doctors in their training are working on Da Vinci. So we really found, we just had 2 new general surgeons and a new OBGYN that joined us. They trained, that's kind of what they're used to. And so, really it's just kind of keeping up that we need to give them the tools to do their job.
Yeah, but Ed, for the layman, it's not, let's go to Uncle Ed and say, I want this new toy. These are not $100,000, $50,000 tools.
Right.
I mean, how much was the accelerator?
Yeah, Brigham and Women's paid for that, so I'm not.
Yeah, but
I'm
it's
not
the investment, it's the investment
yeah,
here.
It's 7 figures, yeah.
You know, somebody put up millions of dollars and they,
Yeah.
I mean, I can't think of many community hospitals that would have said, no thanks.
Yeah,
So they had to choose us. And then the Da Vinci's aren't cheap either.
no.
So it's just amazing. If I asked you, can I get the same care here as I do in Boston, what would your answer be?
I think hopefully I already answered that question, what I just said. I think it's indistinguishable, and I say that having worked at Boston hospitals for the majority of years of my career. I definitely would not be at an organization that I didn't feel proud or could deliver top-notch care, because that's what I stand for, is the ultimate in patient safety, and we strive to deliver the greatest quality of care, the utmost of patient safety we can, and support the physicians and their ability to do that. I don't think you can tell us apart. I really don't.
That's wonderful. Now, we're getting into a time of the year where flu starts to become a common word.
And the next COVID vaccine, and we brought our Dr. Fauci. We brought our Dr. Fauci, so as I said to Al, maybe I won't show up tonight, we'll just have, Peter come.
Only for people that trust Dr. Fauci.
No,
So-
the only thing is you're not from Holy Cross. Otherwise,
It's true.
But now seriously, I have a basic question.
Yeah.
You called me, I got my COVID vaccine. Then I went down and got boosted. Then I got harpooned a 3rd time. Okay, it's been almost a little over a year or almost a year. Do I need to be harpooned a 4th time?
Yes. I think
Why?
everybody should this year get their updated booster, which for most people will be the 4th shot. I think the reality is while we're still really evaluating the data specifically of this new, we call the bivalent booster, which has the BA.5 protection as well, we know from the 3 prior vaccines that vaccines have been the single most effective tool at allowing us to come to this point in the pandemic where people are surviving, even though millions of people are still getting sick from this. And I think that's the most important thing to remember. The vaccines, and now thankfully we have the other therapeutics like Paxlovid that are also helping, but the vaccines have been the most important tool at allowing us to get to this point. And I think we have to continue to focus on the utility they have, even if the vaccines are not perfect, which no vaccines are, in preventing the spread of infection per se. They've been remarkably effective and remain so at preventing hospitalization and severe disease and death. And if we can do that, then we've won.
But is that, I mean, when you hear, well, I've been double vaccinated and I still got COVID, but isn't it more I'm getting a milder form?
Yeah, that's exactly what it's about. The same thing can be said for the flu vaccine, which we get every year, and which I would encourage people to continue to get this year especially, because we're worried that with sort of the changing patterns of viral illness that we could see a bad flu season. Yes, you may get the illness, and that's okay. Vaccines are not going to be 100% preventive against that. But if it prevents someone from dying and ending up sick in the hospital, then that's what it's there for.
Harpooned death. I think it's an easy choice which way I want to go.
Yeah. It seems that way, doesn't it?
Now, is there anything special we should be doing? I mean, when Dr. Newstein came on too many years ago, it came obvious. Wash your hands. Is there anything that you'd say changes between COVID and the flu?
You want to answer that, or you want me to go with it?
No, go ahead, you're on a roll.
No, I don't think so. I mean, we could get super technical with these things, say washing hands is always important, but we know that's not the primary way that COVID is spread. But be that as it may, washing your hands is still incredibly important for reducing the spread of most infectious diseases, so that's important. For COVID versus the flu, not particularly. They're both respiratory illnesses, and so we just need to be cautious about, when we have symptoms, especially being around people, sneezing, coughing. So we just need to not forget that that's the way that these illnesses are transmitted. But most importantly, to make sure that we're protected because we know that the spread is going to happen. So again, getting the vaccines, making sure that if you do get an illness with COVID, for example, that you're in touch with your physician for instructions on whether you're a candidate for Paxlovid, for example, so that you get the right treatment.
But now, it's been about a year. I mean, every year I get a flu shot. And part of it is, okay, they're going to have a new strain. If I remember right, they keep 2, they add a new one. But for COVID, am I getting it mainly as a booster because my immunity's faded, or am I now going for the subvariant protection?
It's a great question, which we don't know all the data on this yet. The theory is with this new, we call the bivalent vaccine, which has directly related to the BA.5 subvariant, that it's supposed to have better effectiveness because BA.5 is more of the circulating strain. We still don't fully have data on that, but the reality is that getting any booster at this point in time is really effective at, again, reducing severe disease, hospitalization, and death. So it may be, at this point in time, less of an issue of whether the newer one is more or less effective than the old one, but getting a booster at this point is really important. Although I suspect we'll see probably some data emerging that this will be effective against the circulating variant, as long as we don't see more mutations and different variants circulating.
But it's a viral entity. It's going to mutate,
Yeah.
no?
Question is how much and how much it escapes the current vaccines.
So I was going to say, if there were no mutations or changes, why would we ever change the flu vaccine?
We probably wouldn't need to, but
Al, I want to go back, if I may, to your question about what can we do other than hand washing, and people might not be happy to hear this, but we still should be talking about masking in certain situations too. It's incredibly effective as well. I think people are frustrated; they've got fatigue from wearing masks, but they're still incredibly effective. So, I wouldn't dismiss the fact of wearing masks in crowded places, and certainly, I think people are frustrated with still having to wear masks in healthcare facilities, but I don't see, the mask mandates in any healthcare facility going away for quite a long period of time. I mean, that's where a lot of our most vulnerable, highest risk people are located, and so, we're going to be wearing masks in hospitals and physician offices and other healthcare facilities probably for years to come, and I think we should continue to be doing so, especially if we have another surge this winter in other settings as well. I didn't want to have the question about what can any individual do go by without addressing sort of the mask issue.
If I could add to that, I'm non-clinical, but and I think people are pretty good about this at the hospital, but if they feel sick, don't come to work. I think that's, it's kind of, I think historically people would work through it, and I think there's more awareness now that this, this could be COVID, and I think that, to me, that's really been an important step, and I think, I know in the hospital we're diligent on that, and our employee health office is very responsive to that.
Well, it seems just logical that if I'm going to a place where you're concentrating sick people, I should take a little extra precautions.
Yeah.
So,
And actually, we worry more about staff-to-staff spread as well,
Yeah.
so, yeah.
So now, as you think through it, are you really getting resistance at the medical facilities for people wearing masks?
Well, honestly, yeah, we're getting some.
Yeah.
Yeah, people are tired. People are fatigued. This has been going on for a couple of years now. They're tired of it. I understand that, but your diligence and your focus on something kind of wanes over time, and it's kind of natural. It's human nature. I understand it, but I think people need to understand our side of it. We need to protect not only them as individuals, and they may feel they don't need or want our protection, but we're not just protecting them, we're protecting others as well. And
But
so,
realistically, I'm tired of being bald, fat, and old. It's a way of life. I mean, there's nothing I can do.
yeah.
So you're thinking about the mask. Am I protecting myself, or am I protecting the people around me?
I'll
I
let
think we know
Peter
both.
answer
I think
that.
we know both.
Yeah.
If you probably remember early on, there was all this debate about whether masks were effective one way or both ways. And I think what we've learned really is wearing a mask does protect you, certainly, and it does protect you from, having your respiratory droplets on somebody else who's nearby you. It's even more effective, of course, if both people are wearing masks. But back to what you were saying a little bit, I think we have a responsibility in healthcare to protect our patients. And I think that means we have a different level of responsibility than the general public might, especially with respect to masks or something like that. It's really our ethical duty to take the measures we believe are necessary to protect patient safety. We probably should have been wearing masks in healthcare settings for years before this, just thinking about, flu seasons, we probably should have been doing it, or even all the time. So I think this is something that probably was long overdue, and we've learned some lessons about public health through this.
How did the flu do while we were wearing masks against COVID? Did we see rates go down?
Significantly. I don't have the statistics sort of statewide or nationally, but just from anecdotally from from not only staff illness and patient care, because we would see a lot of flu typically every winter at our urgent care centers and at our primary care sites, and we saw very little over the past couple of years. But the prediction is that's going to be different this year because
well, people aren't wearing masks.
Exactly. Yep.
Yeah.
Yep.
Yeah, it's a great point. We've seen very little flu activity throughout the past 2 winters, and you're probably right. Although it's probably not only related to masks, I imagine had differences in how we were distancing or congregating with families, and but absolutely, the fact that masks are going to be off this winter, I think makes us all nervous about the possibility for flu, for RSV, for other viruses, what their activity is going to be.
Yeah, kids are going to be sicker this winter too because there was very little infectious disease in pediatrics in the last 2 years.
Yeah, but you didn't have them going to the incubators.
I know. So it's going to be a rough winter for parents of young kids.
The schools, in my mind, for the young kids were just large-scale incubators. Because once one of them got it and touched each other and did what kids do, it just spread through.
Yeah, when the mask mandate went away in, I think, February of last year, was it? That's when, if you recall, there was a huge surge in both COVID and non-viruses that happened, surprisingly, right? Because the incubation began.
And subjectively, we just hear from our employees that get COVID, that it's often, they feel from home that it's children or whatever. It's not really in the work environment. So again, all of that, preventiveness that we've talked about, like masks, it's still a challenging environment.
Well, I remember Christmas, day after Christmas, my daughter called me. Now, like any family, we spent Christmas Eve, Christmas Day. The day after, she calls me and says, "I'm positive for COVID." Somebody that in the school environment brought it to her. I went and got tested. If I hadn't gotten a positive result, I would not have known I had COVID. So when somebody says, well, do you really get milder? Well, to go those 10 days that I quarantined and not know that I had it. And like I say, if I hadn't seen the positive result, I wouldn't know I had it at all, which is a scary movie because I could have gone along and infected people. But it does, in my mind, bear out the fact that it's worth getting harpooned a second or now a third time. What do you think is going to be the biggest challenge we face this year besides, flu is, I hate to say it, but influenza is going to be there forever. What else do you think is coming? Is it worth talking about monkeypox?
We can certainly talk about it. It's definitely been in the news.
If I could just jump in, I think the thing that the thing I've learned and that worries me a little bit is, and I forget whether it was the 4th phase, but one of the things, some of our employees had COVID. Staffing was a challenge, but I've always known kind of within the hospital, we're really interdependent on each other. And we talk in sports like, every team member matters. I've always felt that way in the hospital. So if things, there's a correlation between what's happening in the ED and the floor and the ancillaries, and everyone has to work together or it doesn't work. I think an experience that I've never had in my career or heard was how interdependent we are on all of healthcare. So suddenly we had our typical patient load in the hospital, and we would normally discharge to nursing homes or send the sicker patients, to Boston or Worcester. And suddenly they all had staffing issues. We've never seen that before. And it's like, geez, this patient's ready to go to skilled
Where do you
nursing
put
center.
'em?
We can't take them. We don't have the staff. We're out. And so I that was kind of a new kind of element. And so suddenly our system kind of backed up. It's like, well, we have patients that are a little sicker than we would like to keep them here, or that we need to send them. But for the first time ever, Boston or Worcester said, can't take them.
But what happens now, you have to hold them.
So we have to hold them.
It's not the $250 a day average at a nursing facility.
Well, actually, it's less about finance. I mean, and I've got a
No, but I'm
finance
thinking-
background, but it's like, for most of these patients, we don't get extra payment, we get one payment. But the issue is, nothing moves through the healthcare system. And so, care is delayed. So what do we have to do? We might have to cancel surgery for, and say, hey, we don't have any beds to put these surgical patients in. Or we've had to take some of that staff, and so suddenly, everything just goes downhill.
So the insurance companies aren't on your back, because you're bearing the cost.
Right, yeah. But I just can't describe the stress level in terms of taking care of patients, or because, this is behavioral health patients and inpatient behavioral health facilities, and suddenly you've got patients backed up in the ED. You can't get into a room. You can't get patients from the ED upstairs. You can't get patients that are on the floor out. So that's a scary thing, and that's why we're all in this together, whether we realize it or not. So
Well, if that's the case, then I need my knees done, I need my hip. You're gonna put me off, because you can't
right,
put me anywhere.
yeah. And you know what I've learned? Patients go off pain meds for like 10 days, a couple of weeks before they have their joints replaced. So it's no, you might think, hey, it's no big deal to defer someone that's going to have a knee or hip replaced. They're in agony. You got to call them and tell them that
When my mother had her knees done, it was bone on bone,
Yeah,
so every day was misery for her.
yeah.
But it's not even just truly elective things that get postponed. I mean, we learned from the early phases that cancer screenings were delayed and other things. And so, yeah, I think you were asking Peter initially, what's the next thing to worry about? Is it monkeypox, or is it some other disease that we don't know about? It's staffing. Staffing is the next, pandemic that worries us.
I'd say next, it's going on
Yeah,
now.
the current. The last kind of surge we had of COVID really wasn't about patients, and I mean that we didn't see spikes of patients in the hospital. We didn't see our urgent cares overrun like we were a couple of winters ago. It was the staff. It spread through staff, not in the workplace setting either. It's, someone in this home is sick, and so then that's staff member, and then someone in another family of another staff member got sick, and they all get it. So trying to, going into the busiest time of year for our hospital system, the winter time, knowing that if there's another COVID surge and we're going to be hit by staffing challenges worse than we're having at a baseline, that's the crisis for us this winter, not the flu or COVID itself.
Now, we read a lot about monkeypox. Is it worth having a discussion today about that in the Milford area?
We certainly can, but if you don't mind, and we'll happily get back to it, but Ed and Pat were just sort of reminding me of something, and I was hoping I could
Sure.
just talk about it before we leave that, which is, and you were asking the question, what is most on our mind or most worried about? Along the lines of the staffing and the stress in the healthcare system, I want to take a moment for us to reflect on how hard of the past 2.5 years have been for all the healthcare workers, and those especially who remain in the healthcare workforce. The physicians, the nurses, the respiratory technologists, the phlebotomists, the everything have been day and night working their butts off to do the best they can to take care of patients. Initially, they were all viewed as heroes, and that inevitably sort of, that initial enthusiasm over the care people were providing has waned, and, not surprisingly. People have gotten tired of the pandemic, but I don't want people to forget every single day how much stress and strain the healthcare workforce is under, how hard they're still working to take care of this community. They're tremendous, and I just hope that the viewers who watch your program will take a moment to spread that message and to thank them, because really that's what I worry about, is that they're going to feel unthanked, that they're going to feel forgotten about, that they're going to burn out, and we're going to lose more healthcare workers. So the more we can do to show our respect for them and our thanks for them, then I would appreciate that.
That was well said, Peter, and I think it ties into Pat's concern that we're not out of this in terms of staffing, and it's been a long run, and I think we've seen retirements. I think we've been used to and have never taken for granted, but now realize that people during a short-term crisis would step up and work extra hours, and when you're going into year 4, that's kind of gone, and I think just for reasons we can't explain about the workforce, it's not there. And as you know, we're all still getting older. So I think there's still a great deal of stress on the healthcare system. And I know you want to get to monkeypox.
Well, no,
I mean, the financial, I don't think we should take for granted that, we've got this great healthcare system here. Unfortunately, the Norwood system suffered, this tremendous flood, and suddenly there wasn't a hospital in Norwood. And I think we don't take for granted what we have here. And it's not bricks and mortars; it's really a team providing health care.
Don't throw anything at me, but we know we value MDs. But the nurses seem to remind me of the cops and the firefighters, that you never think about them until God knows when you need them. Mm-hmm. All of a sudden, they're everything.
They are everything, and I think we hear from patients, because that's who they see the most are nurses, and I think there's just not enough nurses, and I think there's incrementally when you lose one person, another person, it puts strain on everybody else, and I think there's no quick solution. And not that it's okay, but it's a national and it's certainly a state issue, and there's been lots of recent publicity about it, and from the bigger hospitals in terms of the duration of COVID, and there's no quick fix for this right now, and so that's definitely a worry. But
now, just to get the monkeypox thing out, because I don't want to skip it. Do we have anything I won't say anything, but is it a concern in the Milford area?
I think in all of Massachusetts, we have to just take this seriously, and all across the United States. Thankfully, the trends in cases has started to decrease over the past few weeks. I think that's a lot related to how seriously people have taken this. I think we've had great direction from the state, from the federal government. We have plans in place in Milford to take care of patients should we need to. We have access to we call it the TPOX, which is the medication through the state, the vaccine through the state, the testing is there. So if patients have symptoms consistent with monkeypox, we're prepared to take care of them. This is not
like, oh my God, it's here. It's when COVID first hit us or anything on that line.
Well, I think I would just say the transmission of it is much less. It's less easy to transmit it than COVID for sure. I mean, the ease with which COVID is transmitted is unbelievable. And monkeypox, it typically takes some extended skin-to-skin contact or sometime contact with surfaces as well for it to transmit. So definitely less easy to transmit, but we still need to be cautious of it.
Well, that's good to hear.
And I would say that, if you're someone who is concerned they may have been exposed or having symptoms of monkeypox, to call your doc first. Don't just show up at urgent care or the ED, because that might not be the best place. Our infectious disease specialists working with Peter and our medical director at MRPG, Dr. Sirocco, have come up with protocols to make sure that we're asking the right questions, assessing risk and likelihood of it being monkeypox, and have systems in place to evaluate those patients and have them tested and get vaccine if needed. But you need to get into that. The best outcome is to get into that go through the right door to get that. So I would say call first if you, certainly if you have a physician within the system.
Is it getting easier for physicians or tougher to take care of their patients? I say that because when I grew up in Milford, there were 4 docs, and all of us could kind of take our lineage back to one of those 4 brought you into the town. And if you went there and you didn't behave and do what they said, Dr. Cicchetti, Dr. Mastriani, they gave you a lecture. And then you start reading how the insurance companies are squeezing physicians harder and harder to see a patient every 13 minutes or something. Is it getting better?
No. It's a tough job. You know, I think electronic medical records were supposed to be some savior of the healthcare system and improve communication within the healthcare system. It's really been a huge burden for providers, not just physicians, but anyone who works in healthcare who has to do documentation. You know, some of the insurance requirements, prior authorizations for medications, tests, et cetera, is more than it used to be. And there's more stuff to know. And, you know, it's funny that you say you used to get lectured by, you know, one of the 4 doctors in the old time. Well, that, you know, the relationship between a provider and a patient has changed significantly. It's much more complicated. It's not the paternalistic approach anymore. You have to be prepared. Patients keep you on their toes. They want to know all the options. They want to, you know, make sure that you're aware of options. They want to discuss. They want to be involved in their care decision. They don't want you to tell them what to do. They want to have a discussion about it. I think that's very healthy, but it also
How do you
is
get
more
that done in
challenging.
13 minutes?
Yeah. I'll let you know when we figure it out.
I mean, I understand you spent a large amount of money on electronic medical records. And it's been very, very nice that I can go to my primary care or I can go to my cardiologist and Dr. Shine he knows everything. He looks it up and comes in ready to go. But how hard is it to maintain that?
It's hard, and it's, you know, it's expensive, but I think, again, in terms of it's challenging to navigate, and I think, you know, Pat, you know, described that. I think with patients and the internet today, there's just a lot more information out there, so it's you know.
You know, and your
It's not
example
easy.
is great, and you stay within one system. Yeah, then all your information, but, you know, you go down the Cape for, you know, the weekend and something happens and you're in the ED in the Cape, they don't have any of that information necessarily, unless they happen to be on you know, the same electronic record and there's some bit of information. But if they're not on the same system, forget it. You might as well have nothing. So
when Jeff Hopkins first came on the show as head of the Taj Mahal Hopkins, the ER, I asked him, what's the one thing I can do to make your life easier as an ER doc? And he said, well, you have a business card with all your medication, with your primary care physician, you know, basic information. And I said, why? You just asked me, I know it. He goes, not if you're knocked out in a car accident. You know, so that hit me because when I had an issue, I went back to Virginia, and the physician I had there, it was 23 years later, he still had all my records. And it just amazed me because I said, what happens if he retires? So I paid to have those records copied, and here we're doing it as part of treatment.
You got to be careful when you walk around with those cards because things change, so you got to make sure it's not stale. That's a big deal. Al, I wanted to make just kind of a few summary points. I wanted to re-emphasize, you know, what Peter and Pat have said in terms of the great team that we have here. We're lucky, and you know, it takes years to put the system in place that we have. The relationships with our academic medical centers, the employed physician group we have, how lucky we are to have that in terms of, you know, a key vehicle to bring physicians to Milford. And really the team at every level that we have in our healthcare system, from the MAs and front desks and the physician offices to the support staff, you know, housekeeping, dietary in the hospital, as well as very fortunate, you know, all of our nursing and physician and ancillary staff. So it's been years in the building, and we're building it every day. I think COVID has been, you know, has been incredible. So we're finishing our third year of COVID and planning for next year of COVID, still thinking that we're getting to a new normal. And I think the numbers don't add up. They don't add up statewide, as we've mentioned. And again, I think what we've really done is taken on, what we can control. And our mission is we want to take good care of patients. And we've been in these situations before. We say, geez, this doesn't add up, but things have worked out. And I think that continues to be our plan. We are very hopeful in terms of state funding, hopefully still in September, that's going to resolve the state issue of the surplus in the distribution, because there's definitely some big dollars in there from healthcare systems that the whole industry needs, and we're making the best plans that we have for next year. I think typically, we feel like we're here often telling you about something new, hopefully bragging a little bit. But I think, for us, the environment is really, really challenging. And I think, again, we can only control what we can control, and we're doing our best to deal with that. So I think we feel very fortunate to be in the position that we're in. And again, looking at the cancer center, looking at the ED, looking at the great inpatient care and the ancillary care, it's, if you told me this 20 years ago, I'd say, wow, that'd be incredible. But, the state of the industry is definitely, very, very difficult for everybody. And so I think that there needs to be a period of bringing the whole kind of communities in the state up to speed on that. But in the meantime, we're going to take the best care of patients that we can.
But you've taken some very proactive steps with, like the urgent care facilities.
Yep.
I was amazed when I went to the one in Milford. It's the same faces that I saw at the Milford Hospital. It's like, wait a minute, this is not bargain medicine.
Yep. Yep.
How's that? And then I went to Hopkinton, and again, there's our system. Depending on where I was, I could go to either one, and all my records are there, or everything's there. How does somebody decide, except for money, because I think the ER is a $500 deductible, and the urgent care is $25 to $50.
I think it all starts with like what's right for the patient. What's right for what's the standard in the industry of where patients should get care. But again, a lot of it is driven at the physician practice of where they can take the best care of patients. And sometimes you want to direct patients, and I'll let Pat speak to this, that are in the ED, they should be with the physician. Other times they show up at the physician, they should be in urgent care. Sometimes they show up and they say, hey, I'm having a heart attack. Why aren't you at the hospital? So I don't know if you want to speak to that, Pat. But I think physicians direct.
Yeah, I was going to say the same thing is, not everyone gets it right, because sometimes, you walk into an examiner in urgent care and you're like, oh my God, let's call the ambulance right away, right? And then we'll say hello. But I think the vast majority kind of learn. I think a lot of it's convenience. It's not, it's the care that they get at urgent care, they could have got at their primary care office, they could have got somewhere else, they could have gotten the ER, it would unnecessarily clog up the ED, so we're fortunate that most people kind of have learned that over time. But, while we're talking about urgent care, they've, the last 2 winters with COVID, just the numbers of patients seen and the access that our communities have had through MRPGs, urgent care has been remarkable. Other urgent cares in the area closed down over the past 2 years. Well, we robbed Peter to pay Paul to make sure that we were adequately staffed, 7 days a week. I mean, I think we were open 360 days a year each of the past 2 years during some of these COVID surges, and really a kudos to all the urgent care staff and the non-urgent care staff who went to urgent care to help out when the numbers were so incredible.
But even the urgent care, when I called to find out what hours they were open, and I said, which one should I go to, A or B? And they said, well, do you think you have COVID? I said, no. They said, go to B.
Yeah.
So they were working with us to say, B does not allow patients with active COVID. A does.
Yeah.
So, I mean, that gave me a sense of relief that I wasn't walking into a group of COVID patients.
Yeah, I mean, early on we made the decision to have sort of what are called, just respiratory care clinics. There was the common term used, and it made sense. We had the ability to do so. It made sense to direct, all those patients to one area. With later surges, it became less practical and less necessary as more people were vaccinated, and we learned more about transmission and sort of safety of PPE. But yeah, I mean, we went back and forth for a year. I mean, I've been in the system for 22 plus years. And I was
He's
the
a
medical
newcomer.
director.
A newcomer to Ed System.
And I was the medical director here for a number of years before my current position. And we went back and forth for years about whether to open urgent care centers or not. And, we finally, pulled the trigger. I think in 2016 maybe was the first one. And yeah, it turned out to be a great move for the group to be able to provide more comprehensive care to all our patients, but also really, I think, for the community. I think having these 4 urgent care centers, I'll give you a teaser, soon to be 5 within the next year.
But I
has
guess
been
what I
really,
You'll have
look
to have us
at,
back next year and find
there
out.
what I look at is you're doing something for patient care, but you're also doing something to take into consideration that not everybody can afford hundreds of dollars copay. I mean, some of the older people that built our town are living on $1,500 a month Social Security. For them to take a few $100s out could mean no dinner or no meds.
Yeah, we want every patient to be in the most appropriate
Right.
setting for what they have, and I think
Right.
I try to think of things a little bit simplistically, but also, I know Boston's sort of a sports town, so I think of the primary cares as the quarterbacks of the healthcare system, and so unless you truly think you're having an emergency, which in case you should go to the emergency room, like your doctor's the quarterback. They're the one that know you. They're the ones that can guide you and tell you where is the most appropriate setting. So I like
but
starting with them
The
because
good news is, let's say I made the wrong call,
yeah.
and I should be visiting Jeff at the ER, and I'm down at the urgent care, a mile away. How long would it take you to say, oh, you belong in the ER? That's 1 minute.
Not
So-
long.
Could be an ambulance bill though, so watch
Well-
out.
Well, again, thank you for everything you've built. Thank you for continuing to not only serve the Milford community, but to serve it with the level of care and expertise that you bring. I mean, it's pretty amazing to me that the little red building that almost could now has grown into a full-blown medical center. And it's all because of your management, your expertise, and everybody that you bring along. I joke saying you're a newbie, only 22 years. But that's not a joke. That's a compliment that there's so many people that are there 25, 30 years, and you don't see that in the medical world today.
And we've got a great team, again, as I've mentioned a few times, throughout our system, and a very supportive community. So, again, we want to be the best community hospital that we can be, and have these relationships and take great care of patients.
Well, the proof was in the pudding, Ed, when you needed to raise money and the community came up with $25 million.
You're right.
I mean, when I grew up, you could have bought Milford for 25. They would have thrown in Hopedale or Mendon on top of it. It's amazing the support you get, but you earn it. And
Thank you.
again, thank you.
Thank you.
thanks, Al.
Thank
And
you.
to our 6 loyal viewers, may God bless. May tomorrow be a better night than tonight. And what we heard tonight is just keep doing what we've done over the last year or two. And protect yourself, protect your family, and protect everybody here at the center of the universe. Good night, all.
Far too long since I've been home. Been running all my life just